members of the public. Thank you very much for joining us. I hope you'll find it really useful. Apologies for absence. We are quite, but apologies from John Child, our Chief Operating Officer, and Nitin Mehta, our Non-Executive Director, joining us online. Minutes of the Board of Directors meeting held on the 3rd of April. Actions, and two parts to this. Read the correct record of the minutes, please. Very much. And the second part is our action log. All of the actions have been completed, with one yet to be completed, and that's because the health and safety report will go, as per the business cycle, will come to us the board meeting in August. So that's why it won't say it's, you'll see that it's just continuing. Don't have any questions given to us from the members of the public, which takes me on nicely to the chair's report. And yeah, I mean, as always, an incredible busy couple of months. Very impressed with the way we are managing, particularly the execs managing all the challenges that are coming towards us. We'll hear more about that as we go through the board papers. I was really pleased that we had what I would describe as an excellent organisational strategy event. So we improved our strategy. We had an event. It was really an engagement event to launch it, and had over 140 people came to the event. We heard from Danny Mortimer, Chief Executive of NHS Employers, about the national challenges ahead, which there are a lot. And of course, Stephen Lightfoot, our ICB chair. We had some brilliant presentations and discussions, panel discussions. It all went really well. And actually, the external feedback we had was of very high level and good quality. And I think, you know, I mean, we had a discussion, didn't we? A few discussions whether we should do this sort of thing, and in the end, it was worth it. And it also shows complete board commitment to the strategy. And Abiola stood up and made that quite clear, that the board commitment and how excellent the strategy is. And of course, we now have that as our footprint for going forward for the next 5 years. I've said already right at the beginning, just informally, that provider collaboratives are really important, and we had a workshop on provider collaboratives during the period of the last board. I just think, you know, with the eating disorders and the forensic psychiatry provider collaborative, these are really important for a number of reasons. I mean, apart from anything else, collaboration and partnership is the way we need to behave at the moment, and the way we need to function, and we do that rather well. So our system partners will tell us. There are provider collaboratives are about you know, maintaining high and improving quality, but also about value for money, in that you invest in the right things, so they're based on evidence where you should be putting your investment. And we heard the story this morning about where you can put money into the wrong areas, and that's what provider collaboratives do. They try to address that. So I think they're really, really important from that point of view. And then the other point is that we are quite advanced in our provider collaboratives, and we also belong to a system-wide provider collaborative, which is really about a major rethink about how particularly our acute trusts operate within our Sussex system. So there are a lot of lessons that we can learn from provider collaboratives in mental health, because we're quite advanced. So they're really important for us as a board. I want to say that just a note there about NHS Sussex Chair Stephen Lightfoot, who's he's stepping down in September. A couple of things on that, as I really have really enjoyed working with Stephen. He's only been a year, but he's a big supporter of mental health, and he's demonstrated that throughout that year, and that's really important. So you know, we're conscious of that going forward, and of course it's great. Well, I think it's good. I'm really pleased that Adam Doyle, the Chief Executive of Sussex, went off to do some work in NHS England, is now back with us. I think that's quite important, because there's turmoil ahead, there's changes ahead, and we need stability at the system level, and I think we'll have that with Adam Doyle. So that's a good thing. I just wanted to say that that we've got council elections. So our council of governors, really important to us. We've done some work over the last year to improve our relationship with governors, and I think that's paid off. We have a number of vacancies, and so the election has started. The campaign has started for the elections. If you could do your bit, whatever you can, just to sort of help with that. We've got a webinar a little later with quite a few participants that will be interested in becoming governor to us. So it's partnership with us. And that's my chair's report. The comments or questions? If not, we'll move on to our chief executive's report.
Thank you very much, Sean. Hi, everybody. So I'll take the report as read. I was also going to talk about Adam coming back into the system and welcome him back into the system as a substantive chief exec. He started yesterday and he met with all the chairs and the chief executives as part of the committee in common and set out some of the priorities over the next period of time and the time of transition for ICBs and the NHS as a whole. And it felt refreshing, and I think as an advocate for mental health, he will be really helpful for us and help with the system leadership. Strategy launch event that Sean mentioned landed really well in the system, and a number of other chief executives of both independent sector, other statutory sector and health organisations have contacted me to ask how we did it and to think about how they can use the approach we did and to develop their own strategy. And we're now on the next phase of roadshows, which I think have just come to an end, haven't they? We're around the last one.
We are.
Roadshows across the organisation, really socialising it within the organisation and thinking about ownership of it at every level of the organisation. I think alongside that, we have our appraisal window at the moment, and we're at that stage where we've got the new system. So where we're doing all of the appraisals in the first quarter. So you'll expect a performance drop where they all went to zero in April when you see the performance pack, and then over April, May, June, it will increase. And I say that because part of embedding the strategy is making sure people have objectives that are aligned with the strategic objectives for the organisation. So we're all prioritising things as we should. Alongside that, you'll know as a board we signed our anti-racist statement and we published it. And I can see that Anil has an anti-racist book which on his table, which I'm very curious to have a look at in anti-racist organisation. We launched our PCREF, which is Patient Care and Racist. We had an event here with partners, service users and members of staff. And we had a community engagement event in Brighton and Hove, and those were attended by Sean and me and executive directors. And I think it signals a sea change, but what we can't do is leave it as two events that we have that launch a really nice statement, but think about what that means for us as a board. And I've asked particularly for me and Teresa in terms of things like violence and aggression towards staff that have a racist element to it, thinking about how we respond to that and how we actually do something about what do we do that's different, and think about that, and that we reported to the Quality Committee, but also how do we, we're setting up the new Mental Health Act Committee and how we look at things like, so using the Mental Health Act with Black men, for instance. So really thinking about what does it mean as a board to have an anti-racist statement and have our objectives around racism and not just being a nice little thing that we've got on the website that we can point to. We've had our CQC report, long overdue report published by CQC. We have to bear in mind it's now over a year since that inspection, so it feels a little bit like it's after the horse has bolted, and a lot of work has gone on, and actually awards are no longer in existence. They've been reconfigured and renamed with new leadership, and so we have moved on, but that doesn't mean we're not continuing the learning that we're taking from that and embedding that across the whole organisation. Couple of other things. I know lots of forums, and this will probably be one of the last times, but I want to formally thank Usman for having been the Deputy Chief Exec in the first 3 years of me being Chief Executive. As a lot of you know, we run it that it is a 2-year period that an Executive Director is appointed as Deputy Chief Executive. Usman very kindly extended his for a year because we were still being established as an executive team, and he stepped down on the 1st of May. And Colin was successfully appointed as my new Deputy Chief Executive, and he's promoted to be Deputy Chief Executive for the next 2-year period. And I think we're in a different stage of the organisation. So what Deputy Chief Executive looked like in the first 3 years is probably going to be look different to what it is in the next 2 years. And we're discussing that as a team so that we're all on board with that and we understand what that means. But what it also means is Colin is responsible for corporate governance for that, and that links directly with you and the government. Finally, I have been asked, we were asked to volunteer to be the lead Chief Executive for the Learning Improvement Network for mental health for the region. I tentatively said, what does that mean? And suddenly became the Chief Exec for the Learning Improvement Network for the South East region. It is, I'm still understanding what that means. What I do know is that there are 2 others, one for elective and one for UEC weights. They have been running for a year. So the mental health nationally has been, is a year later. There is one for each region, and the focus of the work is on length of stay in adult acute services. And I'm very pleased about that because we are an outlier on length of stay in some of our data. So I think being the lead Chief Exec for the region, it sort of puts an added spotlight on us, which, you know, we could be shooting ourselves in the foot, but I'm determined that we will make progress in that. And I've got a national, a regional role in doing that. We had a national launch meeting 2 weeks ago, and we've got an event at the Annex for the region in July, where we're going to really launch it properly. Finally, you'll see on my report, the Chief Exec's report is evolving, and I've been doing a lot of reading about what a good Chief Exec report looks like. And I've decided that what my Chief Exec report looks like is not an example of a good Chief Exec's report. So I'm going to do some learning around it, and I'm going to think about how that evolves, and I'd like any feedback as we go forward. One of the articles I was reading, it should be a view for the bridge, and very brief and sort of 3 strategic messages and things like that. Whereas I think it started off as War and Peace, it's become a little bit more concise, but actually, am I saying the right thing? So I really want to make sure that it is meaningful for you as a board, but it also incorporates your thinking. So please feel free to email me and Dan directly. Dan supports me now with the Chief Exec's report, and so that we can really get it to land in a way that is helpful, not just a imparting of information or rehashing what's in the agenda later.
Right, okay, thank you, Jane, very much. I'm pleased that you've been asked to, or volunteered to lead that regional mental health network. One of the reasons why is that with all the changes to NHS England and to the ICB, the regional office is going to be really crucial, and there will be a lot of delegation and involvement down to the regional office. So very important to us. We work pretty well with our regional office, but it'd be good to get a better.
Sorry, just quickly, there's a couple of engagement things that I've been doing. I've been working, meeting regularly with the Chief Execs of East Sussex and West Sussex, and I've got Brighton and Hove in my diary to think about the impact of devolution and how we work, particularly with districts being devolved, but our integrated neighbourhood teams being on district level and other. The other bit that we've been doing is Colin and I met the Chief Fire Officer for East Sussex yesterday. I had a really positive meeting, and there are lots of areas where we can work together, both in terms of urgent and emergency care pathway, highly complex and vulnerable people that we have in common, but also with the opening of Coombe Valley and evacuation from places like Hellingnigh, and really strengthening our approach in those areas.
Very much. Anna, please.
Yes, I'm so sorry. I'm not there in person. Jane, I mean, I think I'm just going to comment on 1.9 because I think you're right. You know, looking at good practice elsewhere in terms of reporting. When I read this, there were two things that struck me just very quickly. One is that I think it's very useful for us to hear about external meetings that you're involved with, and you've been doing that, you know, really well as Sean does. So I think I didn't see that in the list in 1.9, but I think it's really important that we continue to hear about those meetings and how they're going to impact on our work. And the second is that I slightly worried about the overlap with papers that come later if you're going to do what's working well and areas where improvement is needed, because I think that does come through in the papers that we've got later on. So I mean, if there's a template and a model that you think works with that, great. That was just my immediate response to it, that you could end up with another, you know, War and Peace narrative, because there's so much to say about what's working well and what needs improvement. So it's how to decide what's in your report versus what's in other reports. Just I'm sure you're going to do that anyway. Thanks.
Neil, and then Cathy. We'll take two more, and then Cathy.
I don't think I'm well placed at all, unlike Anna, to make any observation about your report, CEO, but I'm always both impressed and somewhat taken aback by your humility, so thank you. Two questions, if I could. Imi Nunn, the born out of the coroner's findings, our release reminds us that we've improved how we audit, quality of documentation, our care planning and risk assessments. That sounds positive, and it is. What, if any, gaps continue to exist that create apprehensions for you and the team?
Ask your other one as well.
Oh, sorry. Millview. Again, it's positive to hear that many of the issues continue to be addressed. At the same time, are there any ongoing concerns that leave you, again, not dissimilar to Young, concerned that what we're doing and how we're doing, perhaps we need to reflect on further and improve further still?
So I'm going to give the first question to.
Yes, please.
Thank you. Sorry. The first question. It's really what keeps me awake at night are the things that is not knowing what we don't know. It's the sort of unexpected and the stuff that is maybe that we're not cited on rather than that we are cited on. And I think that's linked to, a long history of very good practice across the trust, but not consistently delivered. So it's the inconsistency of practice where I think, you know, we think everything's okay. There have been quality visits and sort of things like that, and everything seems fine. And then something happens where it's shown that it's inconsistent. And it's often linked to the fundamentals of care and communication within the team, things like that. So that's where where stuff that worries me. I can't remember the second question already. Millview. Or in relation to who?
So, TGT and Earth.
Yes, yeah.
What are we doing about it?
Okay.
Can you spotlight those areas of continued concern?
Yeah. So there have been significant development opportunities. We've got OD work going in, and there is an improvement plan which is chaired by the Divisional Director of Nursing and Quality, and it has reported back into Executive Committee. I think that the changes are. There have been changes, but they're not fully embedded yet, is what I would say. And it's within the context of some cultural challenges within Brighton and Hove as a whole, not just Millview, but Brighton and Hove as a whole, that we are thinking about that have been long-standing and talking to partners cross-agency as well.
Thank you.
Yeah, I just wanted to talk about the anti-racist organisation and just sort of reflecting a bit on the current zeitgeist and the kind of waters we're swimming in as a country, really, but the extent to which those sorts of external factors influence behaviours that our staff experience, really, and what kind of approach we can take to that. Because you're right, we don't just want to sort of warm words, but it's really quite challenging at the moment.
I mean, my view is that twofold. One is being very visibly talking about it and not keeping it quiet and not ignoring it is one bit. So I talk about it at the trust induction when I go every time, and I'm very explicit about it. I'm very vocal about it in chief exec's webinars and things like that. So I think there's something about keeping it live. I think there's also about how we look at the data as well in a really robust way, and looking at our protected characteristics and whether there are differences and challenging that. We can't change the external narrative, but what we can do is challenge it by our actions and our words internally without becoming oppositional.
There's an adjacent point I'd like to make. So ECREF, wonderful. ED&I improvement plan, equally wonderful. To what extent are we reflecting upon and hoping, intending to embed I think it was 15th of May, the patient safety healthcare inequalities reduction framework? So that gives us a blueprint, does it not, for an organisation such as us, what we might do further still. And with that in mind, that's the reason why I brought this book today. I'm absolutely with you. Sensitive, delicate issue that we need to carefully around. But until and unless we extrapolate and embed the learnings from this book and all that we know, the lived experiences, as a board, how do we begin to then show leadership in the way that resonate with our teams? And that's not a criticism, but I think there's further need to reflect as a board, individually and collectively, around these issues and themes, so that we're better informed to take better decisions and lead correctly.
So we've got a board workshop coming up on exactly that. So I'll hand over to me, who's leading that workshop, because that's exactly the conversation we've been having in relation to the development of the board workshop, which we hope we'll all be attending. And it's July. July. So it's really soon.
We will have that. It'll be really good. But it's also, I think, adding our own leadership. So when I saw the PCREF programme that we need to do anyway, but we're embracing it, was being launched, and there was a follow-up meeting. I cleared my diary and went to that and made sure that I was good, so did you, and so these are sort of things we can do on top of having an examination shop. But I'm really pleased you mentioned that, Kathy. Good. Thank you very much indeed. And we've now got the Colin Hicks Roadshow for the next slide. So the first two are for assurance. The third one is our strategic delivery plans for approval. But we'll start with the board assurance framework, and that's for assurance, please.
Thank you, Chair. So this is the normal updated cycle of the board assurance framework coming through. I guess just to put it into context, obviously colleagues around the table will be aware that we had a workshop earlier this year where we were looking at the refreshing the BAF so that it aligns with our new strategy and our strategic kind of sort of principles. The intention being that's being worked up in the background and will be presented to the board in August for approval. So this is in the current format still, but it will obviously be one of the last ones kind of coming through in this kind of sort of format. And I think probably the only kind of critical thing to note is obviously the change in the financial sustainability risk, which is highlighted in terms of the BAF increase from 12 to 16, and I'm sure we'll pick up risk later on the agendas today as well. And I think the other thing is about just I think the piece that came out of the workshop previously was the bit around actually, are we really clearly assuring ourselves that our BAFs are effective? And actually, if we go in and seek the evidence, that we can find the evidence to support them. So it moves moves beyond the words. And I think there will be an ask and a drive across all of our committees and subcommittees as we start to implement the new BAF to start to sort of do that kind of internal audit, check and challenge piece ahead of potentially then doing a kind of sort of formal third line audit later on in the year. So that was all I was going to raise at this stage. Thanks, Chair.
And it was, in our workshop, we examined that, didn't we? The need for the committee, subcommittees. Any? Very much, Colin. And then the annual operating plan for the board again, assurance.
So this paper brings through the sort of end of year report for the 2024-25 sort of annual operating plan that we have set up. Follows the same format that we've done the reporting through the course of the year. and provides a sort of summary of progress at the end of the year, which then will obviously align with our annual report that will go through for AGMs, etc. I think the summary of it is that it demonstrates that there has been substantial progress against quite a lot of the different areas that are kind of contained within that. 2 of the 3 kind of sort of breakthrough objectives that we initially set at the beginning of the year have been achieved. The one that I think is has been more challenged, as you can sort of see in there, and the position has been around really getting into really kind of really ensuring that we're using outcome measures as part of our clinical services. And that's really started to become embedded in sort of the DNA. We are definitely seeing improvements, but our expectation is that there will be a maintained focus over the course of this year. And certainly the implementation of the new EPR in November will really assist with that as well. A number of the improvement priorities, again, there has been sort of significant kind of progress made. I think there's probably a reflection around the number and the complexity of the metrics that we probably assigned to these at the beginning of the year when we kind of come to the end of the year to try to sign them off. We've had some discussions around some of the specific metrics we haven't achieved for a number of sort of different reasons, but yet there's still been sort of significant improvement in terms of some of the delivery of the services and some of the initiatives that have been kind of sort of put into place. I think there's something for us this year, and it was certainly kind of sort of came up when the exec had their initial feedback session with KPMG around the readiness assessment for continuous quality improvement, to really think at the beginning of the year about making things really sharp, really, really smart, and thinking about the level of ambition and appetite that we kind of collectively have to deliver that. So that'll kind of come on to the sort of the second item. And then the rest of the update obviously kind of just covers the kind of sort of the core areas which will have been cited through the various sort of committees around people and culture, where we're up to in terms of the kind of the quality objectives that we had, finances, and then also the kind of the activity national kind of sort of performance levels, none of which I was going to necessarily draw the board's attention to specifically at this stage. Thank you.
Thank you, Colin. Yeah. Teresa.
I just wanted to illustrate one of the points that Colin is making. In the quality plan for safety, you will see that we had agreed 14 metrics, and we have graduated 6 of those as green, 6 as amber, and 2 as red. Now that overlaps with the quality account paper that we've got later on the agenda, where you will see, having read it, that actually we will be consolidating those priorities for quality into 25-26. That are really aligned with the ambitions of the organisational strategy. That said, those areas in the quality plan that are partially met and not met will be carrying forward into the work plans that we have for 25-26. And we had a really good quality discussion through our QRMC last month about exactly where those items will be monitored, what the plans are, and where those different priorities will be monitored. So I just wanted to give that assurance that those areas of safety that are partially met and not met are carrying forward into the work plans for the current financial year.
Okay, thank you. And Javiera.
I think I just wanted to looking at the annual operating plan and putting some of the different pieces together, just to raise that, even as we were able to achieve some of the finance savings, we can see that we achieved some good quality savings, some good quality achievements, and that we didn't achieve the finance savings by reducing our care. And I think sometimes that gets missed when we talk about making finance savings. We were actually able to show that we've improved safety and experience for patients, that we've done some transformational stuff with people out on the streets in emergency case. I just wanted us to not forget some of the the great things that we've done, even while we've tried to achieve the finance savings.
It was said, and I think because that was always our plan, wasn't it, was to look at the financial savings in light of transforming our services to make sure that we match with what the evidence tells us, and that's what we have been doing. I mean, it gets more challenging, but that's the factor. Thanks for saying that. Yeah, Anil.
Okay, very echo that which Javiera said so very well, and thank you, Teresa, for what you mentioned to answer the question. If I can take you to, I don't know, it's on slide 23, and it's activity and performance plan 1. It's the outturn from the previous year, 23. So it's activity and performance plan brackets 1.
Okay, I mean,
It looks like that.
Yeah.
Sorry.
It's just taking time to load.
Oh, is it? It's not free. It's like my brain, it's blank.
ask a question anyway.
Sorry, yeah, that's right.
Have you got it up, Colin?
Yeah, no.
So when you evaluate that outturn position, curious to understand where you believe the greatest opportunity for improvement is by division or specialism, perhaps, when you look at that. It'd be interesting to know. There's a lot of numbers there, a bit of narrative.
So sorry, what was your question?
So where do you, looking at that, when you reflect on that, where do you think there's greatest opportunity for improvement? So that's the outturn previous year. As we go into this year, what does that tell us in terms of our focus areas and where there's, so when I look at patient seen, contacts, community urgent care, is there some specialist division or indeed geographical area that we need to just focus on as a board, in committee, or not?
The other part of the question is that with that data, where do we get flagged up the important areas, the priority areas that we need to be focusing in on? Jane.
So my view is that there's something about over the next year is I think one of our key priorities are the people that are waiting for 12 hours in ED for a bed. But actually, I would like to see the number actually coming into ED less, and therefore you'd strengthen the number of contacts in community in crisis response teams and the community services are pushing it down in a different way. So I think there's something around how you move the activity to somewhere where it's least restrictive and least interventionist and keeps people in the community. So although our focus is on the 12-hour breaches, I'd want us to keep a focus on our community work and our crisis response work.
We'll add to that.
So I think I'm also trying to link your question around risk assessment and CPA as well. So to Jane's earlier point, one of the biggest challenges of any healthcare organisation, ours as much as any, is the consistent application of practice in a way that is recognisable and evidence-based. On the risk assessment and CPA in particular, there's an awful lot of work that is going on at the moment to modernise the system in line with the new EPR. So just yesterday, I was going through with the team to our redesigned risk assessment form. Just having the form though is not enough. You then have to have a training program which explains the evidence base and the rationale behind it, and then you have to have systems in place to monitor its application as well. The same is true of care planning and CPA. We are being asked to phase CPA out and replace it with a system. And again, we're incorporating, so in that particular case, Dialogue Plus, there's a way of documenting and planning care as well. And again, that will require a training program. So there's an awful, I suppose what I'm trying to just get across is that it's not so much about where are we concerned, it's about how do we have a modern system that makes sense to our clinicians, that they're aware of, that it's evidence-based, and that we have the systems in place to monitor its application, so that it's consistent across the entire organisation. Because quality, consistency is fundamental to quality. In a way, I would much prefer a mediocre system that is consistently applied than areas of really good practice, because that's how you then build.
And final words.
Yeah, so just, I mean, again, the specifics of slide 23. So I think as we move forward during the course of this year, one of the things we're going to start doing within the finance reporting is much more focus around the reporting of just core activity performance, because what we're really good at doing is reporting finance, reporting quality, but we don't look at actually the volume of people seeing where we're seeing them. So I think it's absolutely right to highlight it. And what this data, I think, where I would go with this is where this will come through at Committee for Finance Investment, for example, is we've set up a new productivity group, and that productivity group has three very specific purposes. It's looking at contacts per clinician, clinical whole-time equivalent, in effect productivity, and length of stay. And those are the metrics that will flow through there, and then they will flow into finance and investment. But I think this is the kind of activity that we will need to get in. I think there are questions, we won't go into it now, but I'm happy to pick questions up with you afterwards in terms of, for example, like an answer that it looks like it's had a massive increase, but actually what we know is that's just an improvement in recording as opposed to an increase in activity. Those are the kind of things we'll need to get into to really set our baseline correctly for understanding what do we do, where are we doing it.
Thanks, Osman. And then before we move on the top left there on the screen, Anna, in the little hand, I've just please.
Hello, thank you, Sean. So I've got just a couple of questions. One is a very quick one to understand on slide 14 why improvement priorities for learning disabilities are not progressed. I don't need the answer now, but I'd just like to understand that on slide 14. Second point, so I've just got 3 points. Second point is in relation to, our ongoing challenges around PROMs and CROMs. And I think what we're saying on slide 5 is that we're now shifting our targets. So we're prioritizing patient reported outcome measures over clinician, because that's the direction of travel from the national guidance. Is that correct?
Do we take it? Yes, yes, basically is the answer to that. There is national guidance where they're definitely pushing nationally the PROMs much more so than the CROMs, which is what we're trying to kind of make sure we get built into the system itself. So yes, is the answer to your second question. In terms of the first one, Anna, I'm happy just to feedback now, and I can feedback out offline. I think there wasn't a significant programme of work that was put forward in 24-25 under learning disability. So that doesn't mean that there's not a lot of improvement work going on within the service under the kind of sort of the banner of just BAU improvement activity. But unlike some of the other areas, there wasn't something of a big enough sort of substance, if you like, that it then became a kind of programme of work that we then corporately resourced through the year.
Okay, so maybe that needs to just have a bit more of a narrative, because it does look to me like there's nothing going on, and I think that's, as you say, that's not an accurate reflection of activity. Can I just make one other point about productivity, and picking up on Usman's point? I'm really, I think this is something we're going to have to tackle, but I just have a concern about not taking into account acuity. Yeah, so I think both in terms of the profile of patients and the increasing complexity that we talk about all the time, but also, where you have patients who have multiple, co-occurring conditions. I just think that if we're too reductionist in our measurement of productivity, we could really fall over. So maybe that's not the case, but I just want patient acuity to be in there, and complexity as well when we're thinking about how we measure this.
So quite agree, Anna, and so performance needs to be contextualized. So the performance of a crisis team, the way you measure it and the expectations are very different to that of a neighbourhood mental health team. And your benchmarking needs to both look locally at the peer services, but also at national guidance. So if I take a gatekeeping activity of crisis team, we have got inconsistent practice across our crisis teams in our organisation, and also inconsistency with the national model as well. So that's how we'll be looking, and obviously they're working with a highly acute population. So performance has to be, you're quite right, very contextualised.
Okay.
One bit I'd say is having worked in the NHS for over 30 years, this has been an ongoing conversation that I think we have avoided in mental health because it's too difficult. And at some point, we're going to have to make the decision that it's good enough. And I think the National Mental Health Team is doing work about what the productivity metrics are, and they're going to be delivered across all mental health trusts. So you're comparing apples with apples and pears with pears. There will be flaws in that, but I think we just need to bite the bullet and use it as an aid to scrutinising, discussing and planning our work going forward, and be mindful that we could get paralysed with trying to get the perfect tool.
Thank you very much. We'll need to move on, but thanks for that. Colin, the last paper is strategic delivery plan, and that's for approval.
Thank you, Chair. So this is so obviously we've just talked through the kind of the closeout report for 24-25. This is an update to the board in terms of the strategic delivery plan for 25-26. So obviously colleagues will be aware that we've done a lot of work with the board looking at the development of the strategy, the strategic objectives. We previously agreed the in-year strategic objectives, of which there was 9. What we're bringing through here, if you like, is the new way of trying to describe and start to streamline our activity. So I realise the structure of this is quite different to the previous paper because we're trying to move away from having a siloed section on each of those, a siloed section on finance and another one on performance, etc., but actually really think about how do those things all integrate to contribute to the delivery of our kind of sort of our strategic objectives. The main content of the report runs from slide 10 onwards. So the first section of the report is just the kind of the contextual piece that hopefully continues to reinforce what we've all previously kind of sort of agreed, but also how it starts to wire together. And I should say that we're sort of in the process of sort of developing this at the same time as doing the readiness assessment, as I mentioned with KPMG, a lot of which is about actually how do you hardwire your strategy into your delivery mechanism as an organisation to ensure that kind of everything is aligned. So there's a little bit of redesigning the aeroplane as we're flying type analogy. What this does hopefully is it gives clarity to board members in terms of the breakdown between what are the 4 key strategic initiatives that we're currently working on, which will go across the totality of the strategy, those being around the green plan, suicide prevention, leadership and culture, continuous kind of sort of quality improvement, and actually what is some of the detail that's being developed by the responsible executives across the team in terms of the in-year expectation associated with those. It then goes on to describe more specifically the sort of the 9 strategic objectives that we have previously agreed, and starts to flesh out the detail behind those in terms of clarity around who's responsible for them, and then again, how do they start to kind of sort of build out, and where are there particular nuances within our different operational clinical divisions, recognizing that one of the key things that's really important in our kind of sort of purpose was that word consistency. And that recognition that a lot of our divisions are at different starting points when it comes to some of the objectives that we're sort of setting for them. And then the last section then just refers to what are the we've reduced it down to 10 sort of kind of key programs of transformation that we also have to sort of be continuing to deliver. So these things very much should be at a start, a middle and an end, and we should be able to kind of close things out. So you'll notice on there at the moment that we've taken that in 24-25, we had a very specific programme around older adults and dementia care that was associated with standing up enhanced community provision in East Sussex, the change of award use. At the moment, we don't have an equivalent programme of work going into 25-26, so there isn't any reference to kind of older adults in there as a standalone programme, albeit recognising there's a lot of work to do as establishing our neighbourhood mental health teams and within the crisis kind of pathway. So again, a lot of this is about trying to kind of refine down our activity, although I appreciate it still looks a lot, but trying to refine it down, give it some better structure so that we can really see how the different elements contribute to the overall delivery of our sort of strategy, and then we'll be able to kind of be able to measure and track more effectively throughout the course of the year. And then the last section again just ties the kind of financial piece underneath this as well. And I guess the reiteration from all of us is that we've identified that one of our strategic objectives is to deliver the financial plan, which we'll talk about more later on the agenda. but always seeing that as being one of the elements, one of our kind of sort of objectives that, and it is weighted no more highly or less highly within this kind of context than suicide reduction, physical health, etc., etc. So yeah, so happy to take any questions here and now. And I'm also really happy to take kind of feedback outside of the board as well around this in terms of just how it kind of iterates forward, because I recognise it is kind of structurally quite different. And I suspect we'll come back to this when we have a subsequent board workshop, when we'll do the playback from the readiness assessment. We'll bring KPMG in to do that with board members as well.
Very much. We'll come to Kathy. I think it's an excellent document. It's so comprehensive and there is so much going on, but we have refined it down. I can see that. I agree it's a better structure. And we have talked when we were developing the strategy about the KPIs and measurements, and they're here. I think it's a great document for us to refer to. The only question I'd have is when in terms of the business cycle, when do we come back to this during the strategic period? And then I think.
So I think we need to. So the intention was to report back to on a kind of a quarterly basis.
Yes.
I think I did need to work out with that just when what the board cycle does, because the board meets on a bi-monthly basis, doesn't it? So I just need to work it through as to how we kind of sort of factor it in. But I think we need to be really, really razor sharp in our focus through the course of this. I guess the other thing just to sort of say is next year, what I would expect is that we would be seeing this earlier, not in June. The reason we're seeing it in June is obviously we were still developing our strategy and signing off all of our objectives. So there's a sort of a sequencing piece. So I would expect that we would see this pre the financial year with the financial context stuff with NHS England. So that at this time we'd be starting to tell you about, and this is what we started to do. We may not necessarily see the outcomes yet, but we'll be able to evidence that you can see, movement in terms of the specific actions.
Very much, Kathy.
Yeah, I mean, I thought it's a great document as well. The other thing I really felt about it was that I felt I've been on the journey and I recognised everything and felt, yes, this is something I really feel I've signed up to. I suppose just, and this might be a failure on my part, it's still quite confusing to map all these different strands together. And I got particularly confused between strategic objectives at 12 to 18 months and the organisational projects. And I wonder if really the organisational projects are the delivery vehicle for the strategic objectives. I just think it's going to get really confusing if we report against those and then we report against all of the and are we going to have an overarching transformation board that pulls all these strands together and manages the interdependencies? Well, I mean, that might be part of the KPMG work, so I mean,
So I definitely will be part of the KPMG work. I think there is and I think some of the initial feedback from them has been, you've made some great strides, but you need to go further. You do need to go further. So I absolutely think there is that refinement. What we have done is we have already mapped through the strategic objectives in terms of the internal assurance. So the strategic objectives are being held at a divisional level, and they're being assured through the divisional IQPR programs. So those are the monthly, bi-monthly meetings that Jane chairs. The organisational kind of sort of projects are the things that require all of us to kind of come together to deliver. So all the kind of corporate services need to kind of come in alignment. And that comes through so we have a transformation board that Lisbon and I co-chair. So it comes through that, and then it will feed up into a kind of sort of board committee. So we've done the plumbing and wiring underneath, if you like, in terms of both of those two things. But I absolutely believe that, as we further refine our approaches through the course of the year, we will need to simplify and tidy up further.
Good. I will take just two more then, before we go to the other.
Yeah, I agree with you with your sentiment, but I'd go even further. I think not just this presentation, for me, I found it incredibly persuasive and credible. But I think over time, when we look back, yes, there's a bit of refinement. KPMG will come in and tell us stuff, and I think it will be seen as a very synonym of best practice in this area. I think that's how good it could well be. I take your point about how it distills into business as usual, our practices, and we'll see that. But so that's an observation. My question, if I could, if you look at slide 12 first, I think, Oliver, something that you set out under suicide prevention, I'll just read it out so you don't have to go to it. It says this, fourth bullet point in, resource constraints limit the suicide prevention programme due to insufficient budget, staffing and organisational focus. With that in mind, when we look at slide 9 and the strategic objectives, 12 to 18 months. If indeed he's not here, he's gone when I knew, but he probably won't. We have a contingency of just shy of 7 million. I appreciate keenly that that's likely to be eaten in. If indeed delivery of our SIP enables some degree of financial latitude later on in this financial year, when you, with that in mind, just as an example of suicide prevention objective, when you look at that list of strategic objectives, where do you feel that where is there perhaps a need for additional resource allocation in order to meet those objectives?
So we have to live within our and I think this is much more. So an original paper was to have the not necessarily the best approach anyway to suicide prevention. It's much better to be embedding it within the divisions. It's also I think that simplifies the issues as well. And so what we've done is we've used what resources we have internally already in place to. So I've asked my deputy, suicide prevention, and James Atkinson is now working with. They are working on the plan as we speak, and a part of that plan will include divisional representation for suicide prevention leads in each division. As I understand, the specialist division have just appointed someone in that role. The divisions are taking a slightly different approach. So West Sussex has asked for one of their senior clinicians to take it within their existing role. We've moved away from an all singing and all dancing funded central team and more distributed, basically, using what resources we have. If that makes sense as well.
Nothing would unless we had another few million quid, but there we are.
We don't always do with more resources.
We have a contingency. And I think if we're doing well with our SIP, it may translate into a bit of like financial latitude. I'm looking at you, Ashwin. Financial latitude, because when I read that, it begs a whole number of both questions and then focus on.
Really well made, you know. We will be looking at that and looking at how we do with our SIP as we go through the year. Just need to, I want to give enough time for the quality item on the next agenda item. And so we can take Anna's and Abiola's together. Abiola, we'll take it together and then.
Okay. So yeah, my question I'm sort of zeroing in. I think this is more for you, for me, you know, and for us about widening participation. And when we did the strategy launch, you know, and I stood up. One of the things that I said was part of our values is accountability. So I think as a board, we also, you know, taking accountability for some of the things. So in terms of the widening participation, it does say that we're going to try and increase the number of work experience placements. Now we have a really diverse board in terms of, of our protected characteristics and all of that. So I think, you know, we can do a lot to try and get more people involved in the work experience. And I know that it has been released that there was work experience for relatives and friends and people who work for SPFT. And I just wanted to say, as part of accountability, I made sure that I shared that, you know, and I'm not going to tell you who because this might be unfair on everyone else, but I do have some people who have applied to do, work experience. So just wanted to say that even as a board, we should try and make sure that we're being accountable for, you know, some of the things that are happening.
Just very quickly, it's just to thank you for that, Viola. But I think that I wanted to just link that into with the point that Neil made earlier, as this is an example of when we make some of those strategic objectives and we see cascade through the board in terms of NEDs and executive directors and members of our respective teams as well. And but for the purposes of minutes, our work experience program launches on the 28th of July. And we have 30 spaces for families and friends of our staff. So that is us leaving that already from on the paper and bringing it into life. Thank you.
Please.
Thank you. So I just want to say I agree. I think this is a really important document. I think, you know, there's an enormous amount of work's gone into it. I really commend it. I think for me, just just two things. One is I think that for example, on page 18, the very specific, and we talked about this at Quality Committee, the very specific localized. So you've got specific targets locally agreed, and I think, you know, that is going to become, you know, more and more business as usual once we've got, you know, our neighbourhood teams established, our 15 teams. There's going to be much more of that, and that feels like the right way to go, because it's about people in particular localities, whether that's wards or in community, agreeing what needs to happen and then monitoring against those targets. And I think that is a model that we want to encourage and support. And the second point, I just want to come back to Anil's kind of challenge, if you like, about, you know, the funding. And it seems to me that you know, recurring themes around capital spend, you know, ligature doors, having enough resource to provide training to staff on suicide prevention, suicide ligature awareness, whatever we're going to, those sorts of areas are where we absolutely should be spending more money in order to effect maximum impact and achieve our strategic objectives. So there are areas like that where if we had more money, we could do more, and we would do more to protect people and prevent harm.
Thank you, Anna. Did you want to respond to that, Jane, or Usman?
I think yes, and we know that the ligature incidents we have are to do with failings in our clinical practice, not because of ligature doors. And I think we sometimes get sidetracked that if we spend money on estate, it will mean an improvement in safety. The bigger improvement in safety is consistency and the quality of our care. And I think we need to be really clear about that. And that's what we need to be driving. And that links more to the training and development than to the estate. So I just want to balance it there.
I think Jane's covered it off. I think, Anna, though, it's a fair point. And I guess what I'd say is we do and will always operate within funding constraints. And then it's about the choices we make around those and how we prioritize it. And I think we have a really good, robust clinical prioritization process, in particular for when it comes to capital, around how we deploy the funds that we have got. But as Jane said, and I think as Oliver said earlier as well, I think the real challenge for us in that space, and it's in our objectives, is about safe, consistent care. And if we get the consistency bit right, I think it doesn't take away from the need for many of the other things, but that is actually, I think, one of the key things. And
thank you very much. So can I move to approval of the strategic delivery plan? Yes, I see. Thank you very much. Anna, we're moving on to quality. The Quality Committee on the 14th of May, 2 reports, monthly workforce metrics, and then we've got the quality account that we'll go to Teresa for. So please, Anna.
Thank you. Can you hear me all right? So take the report as read. No new escalations and no change to Quality Committee risk scores on the existing BAF. But noting that Quality Committee very much welcomed the revised approach to BAF that's aimed at ensuring greater interconnectivity and functionality. So we're part of that conversation. We're looking forward to seeing that developed. We very much welcomed the progress on addressing vacancies and reducing agency spend, and recognising that more work was needed on this. And I think in particular, tackling variations across the patch. We noted the sickness absence rates remain a concern at 5.2%, and we felt there was needing to be a greater focus on this to bring it down below 4%, which I know everybody is keen to see. The people plan review, which you've got in your papers, we really found that incredibly helpful and informative, and a very clear picture of what happened in the year that's passed and what is going to happen in terms of going forward. And I think on the other sort of points I just wanted to make is that we very much welcomed the progress on downward trends in incidents of self-harm overall, noting the variation in different settings. We talked about, how that can be addressed. Downward trends in medication errors and bed delays as well. Improvements in patient safety reporting with the new focus on multidisciplinary team approach, which is, I think, starting to have an impact. Again, we noted the new therapeutic engagement and observation policy, which has been introduced earlier in the year, is also beginning to have an impact, which is very, very welcome. I think the provider collaborative reporting is getting better in terms of risks and mitigations, although there continue, as we heard at the workshop with provider collaborative, the continuing challenges with bed closures and staff shortages. And the other reports, I think, are either later in our agenda or they are attached. We really commend our annual report to the board, and I think it demonstrates that we have met our terms of reference for the year 24-25. Happy to take any questions.
Well, thank you very much. Any questions? Kathy?
I was just going to ask a question to me, actually, see each other down the table. There's obviously a lot of reporting in the press recently about directing for travel on the use of agency staff, and that potentially, according to headlines, being banned, if you like. I just wondered how that sort of impacted on our work and what our thoughts were and sort of issues in relation to that sort of thing.
Thank you. These feed into the planning, or our annual planning that we've done this year. So we did get a heads up. So the planning guidance came with very defined instructions around the percentage reduction in agency and the percentage reduction in bank spend. So our financial recovery plan has programs of work that have been built with the intention of ensuring that we achieve the requirement, both in terms of increasing productivity, but also reduction in the use of. So we're not doing a random stop using agency. It's introducing. So one of the largest program, for example, is a workforce optimization group that's supposed to save £8 million, and it's all built around rearranging how we offer care and how we work and how we use our multidisciplinary teams. So it's in doing that we then see the release of bank and agency, in addition to all of the other work around retention. So that's the biggest aspect. And Usman and I meet with the IT monthly to then provide an update in the trajectory that we're expecting to deliver on. And month one, we're on track on that, which I'm sure Usman will talk about when it gets to the finance.
We've received both reports. Thank you very much, Jenna, and the report from the committee. So just finally on this quality section, the quality accounts for 2024-25. We need to approve this because it published to go up to head office.
It will do.
Yeah.
Assuming that we all agree. Organisations are required to produce a quality account if they deliver services under an NHS contract. So this is our annual quality account. When we provided a quality account, we didn't yet have feedback from the NHS Sussex. We have now received a letter from them with full support and a reflection from them of the work that's gone into the quality space this year, and the candour and vigour in which the organisation has worked with them in quality space. That's good, and I will add that report. This quality account reflects 5 key focus areas. The trust as an employer of choice,
sustainability, partnership working and improvement, and really importantly, our values. It reflects on the quality priorities of 24-25. So you heard me speaking about those earlier, that we discussed earlier. And it details our quality plan for 25-26, really very much linked to the delivery of our strategic actions. Of note, the commitments to reduce ankle and non-ankle ligature incidents with 0 inpatient deaths by ligature, the length of stay reduction and the waiting time improvement. The quality account also references a range of clinical audits. Those are reported on towards the end of the report, including but not limited to dementia, national audit, leader, psychosis, inpatient falls, to name a few. So I will pause there, Chair, and very happy to take any questions or feedback.
Okay, Dan and Anil.
Oh, sorry, me first.
Yeah.
I was just going to say, thinking about the last year, we strengthened the alignment of our work across the 3 domains, and it feels like we've come a long way in that time. That's what we need to strengthen in the year ahead. AR will support us in doing that, continuous improvement, support us in doing that, because it's partly about the triangulation of data and learning in order to inform our action. What I would add to that as well, it's about building on the work that already happens in divisions. And I'm thinking particularly about an example we heard from West Sussex, a quality performance review last week, where the team had triangulated the learning across quality data, performance data, workforce metrics in order to diagnose where there was an issue and where there was a need for specific action.
Pleased to know there'll be no ornate rambling questions and observation, if I could. When I was reading this, very persuasive statement, it reminded me of Ned's responsibility. On one hand, we're here, amongst other things, to probe and challenge, aren't we? But on the other hand, it's important that we support. And it's in that vein I say this, although a sobering for me a reminder of all the challenges that continue to exist, but it's also, I think, a profound summary, not just of the achievements of the breakthrough objectives, but it speaks eloquently to the capabilities, not just around this table, but across this organisation. I think we shouldn't forget that, but also the very considerable efforts by so very many in this trust to deliver compassionate, safe, high quality care, without which the privations for many of the most disadvantaged in our communities would be made a lot worse. So that needs to be applauded. So thank you.
Right.
No,
I'll ask some question later on.
I thought it was coming. Good. So the quality accounts report be approved for further work, for further publication.
Just one. See that there are bits missing at the moment. Some of the dates, so I think once we have that in, we can circulate it, but it's not material.
So we have received, yeah.
But it's not in
That's not in
Yeah.
Thank you. See you.
Yes, hi. Hello.
Oh, there we go. Oh, lovely. Good morning. So please, I mean, we're quite restricted on time. We've got 5 minutes, so please go straight into it. Yeah.
I will. Okay. Yes. Hello, everybody. Sarah James, Guardian of Safe Working. So I'll run through this report, which is to assure the board that safe working hours for the resident doctors are being well managed. The key findings are, which you hopefully you've all got access to the report to have a look at. There were 82 reports in total for this year, 1st of April 2024 to 31st of March 2025. And that is almost double last year, which was 43. And in the previous years, there were 32 for the whole year and 25 before that. So the reason for this large increase is there was a systematic rota error which came to light through exception reporting, and the resident doctors were advised to continue reporting a breach in their hours, with advice from the BMA and other guardians across the country until that issue was resolved. I'm really pleased to say the Trust worked very swiftly to resolve that issue. So the actual issue was that the rotas from their inception, whenever they were very first came into play, did not involve a 15 minutes handover time in the morning between a night shift and a day shift. So those resident doctors had been diligently always working to do that handover, but not being paid for it. It came to light through exception reporting, and as I say, that's now been rectified, and the rotas are correct going forward from April the 1st this year. There's an issue of back pay, which is still ongoing, whether that goes back the whole way to when the rota issue came into inception, but that's still under discussion in the MNC, so I can't report any further on that. But going forward, all is resolved, and the current residents have been back paid for their time in the trust. And just to let you know, there were 19 exception reports for this quarter, which compared with 44 in the quarter before and 14 in the same quarter last year. So we could see the issue resolving through the number of exception reports. Moving on to other types of report, there were 7 immediate safety concern issues this year. I won't go into all of those. They've all been described in detail in the quarterly reports. They were all resolved quickly, appropriately, and effectively. They involved such issues as being asked to cover 2 sites, a resident covering Eastbourne and Hastings at the same time on quite a busy shift, another one where a consultant wasn't available on a mobile due to mobile signal issues, and then there were the 4 out of the 7 were actually a batch of misreports. So actually you could say that was 3 reports. So I'm satisfied there are no really ghastly major immediate safety concerns. They were all relatively easy to resolve things, which did get resolved fairly quickly and were appropriately reported. Then this year we've had 9 reports for lack of service support. So an ongoing issue previously had been lack of SNP cover at Princess Royal Hospital. That this year the number of reports has gone from 18 down to 3 this year. So that issue seems to be less reported, less of an issue. So I think they've generally got more cover. There's a new issue which is creeping in through exception reports, which is around call outs to the nurse-led haven units, sometimes more really for doing routine work rather than which shouldn't really be part of emergency duties for the residents. That issue is continuing to be reported and is going to be looked at in the resident doctor forum in more detail this coming July with appropriate managers there. But it's not a dangerous issue. It's more that the resident doctors are being called to do routine work because the routine medical work perhaps wasn't put into that. It's meant to be a nurse-led unit, Havens. So then we are doing very well with exception reports due to missed educational opportunity. There were only 3 this year and only 1 this quarter. So there isn't any significant service barriers for resident doctors attending their education, which has a very positive knock-on effect in terms of when you want to attract people to apply for our rotations. It will help to give the trust a good reputation around their educational training. And we didn't have any exception reports for foundation doctors missing self-development time. So that's all good. Then moving on to rota gaps. So we continue. So the annual data shows that we had a total of 30% of shifts not covered as per the planned rota. The previous year it was 42%, so it's lower. That's most likely, well, it would be due to the fact we had the industrial action in the previous financial year, so there were a lot more shifts that need to be covered as per not planned by the rota. 30% is sort of those around previous years before. Last year it was 25%, 27%. So those this happens because you do have people, you have sickness, you have maternity cover needed, and sometimes you have less than full-time, well, there's quite a few less than full-time trainees as well, so it's not one trainee covering the whole rota block, it's split between two people. There were 18 recorded occasions this year where the consultant acted down, and that compares with 4 act downs last year. So, and we don't have any information about why that was, but that is presumably when a locum doesn't turn up, and all other attempts to fill the gap in the rota have failed. But we are recording that data, so we'll keep an eye on that. Again, that tends to be fairly steady, but that was a little higher this year than previous years, so we'll just watch and see how that goes. And then just to say, think about the qualitative issues. We still continue to meet 3 times a year for the Resident Doctor Forum and the Fatigue and Facilities Group. The Resident Doctor Forum looks at operational issues that resident doctors might be facing, and we invite members of the senior leadership team. We can invite specific people to attend to talk to specific issues, as is happening in July with the Haven. And the Fatigue and Facilities looks more really at the well, exactly those things, the facilities for resident doctors out of hours, their room accommodation, issues like bed linen, is it clean? And the only thing really to highlight is there's an ongoing issue about consistent access to hot and cold food and drinks when they're on night shifts or long day shifts across the trust, and that is something which is a contractual obligation for them to have. But I think it's tricky with our trust because we're not in one big hospital building. We're lots of different sites all over the place, and some of them are smaller, but we have regular attendance from both fatigue and facilities who've been incredibly helpful and listen to the residents and are lobbying to kind of get new machines with hot food, and they keep us updated about how that's going. So we don't feel we're hitting a brick wall. We feel listened to, and that the issue is understood, and it's an issue that affects all members of staff. And then the only other thing with next steps, just for me to highlight really, is that there are some contractual changes to the Guardian of Safe Working's role and to exception reporting that will need to be implemented by trusts at the moment. The current date is 16th of September. HR would be taking a lead on these changes. So the easiest way to describe this is that the resident doctors, with their contract that they when they had their industrial action and they've renegotiated their contract, one of the outstanding issues that's very recently been resolved is the fact that they were, as a national body, they were unhappy about the exception reporting system and wanted to be able to report directly to HR just to claim hours overworked. And I think, not in our trust, but I think in some of the acute trusts, there's a stigma attached to exception reporting, and the resident doctors are genuinely worried that it will affect their career. They'll be seen as kind of not just complaining about things, and so they want anonymity. So the new system, in some ways it won't be as good for me as the Guardian overseeing it, because I won't know who's reporting what. It'll all be anonymised according to their payroll number, and they will just report very directly to, or they will claim directly to HR for payments. The educational clinical supervisor, who currently needs to sign off an exception report, won't be involved anymore. They will literally go straight to HR to make a claim. So there will be some implications for the trust in terms of the software will need to be revised. I'm hoping to be invited to meetings with HR about implementing this. As it's getting fairly close to September, so I'm hoping that will happen over the summer. I could say more, but I won't at this point, but happy for questions.
Yeah, we won't take too many questions, but I mean, thank you for all you do to manage the safe working practice of our junior doctors. Oliver, or for me, anything you want to add?
I just want to say again, reiterate, thank you, and it's very helpful for me, given the independence, Sarah, that you're bringing to this It feels a long way away from when I was a house officer at Canterbury Hospital.
Yeah. And I'm sure those last issues you were raising about working with us to going forward, any changes, we will of course do that. So one, yeah.
Thank you, Sarah. It's a really, I've got two, but one of them's a little bit pedantic. When I was looking at the report, sometimes it said resident doctors and sometimes it said junior doctors, and I know that
I'm wondering, you might have had, oh dear, I wonder, because what happened was you might have ended up with the revised copy, because I did send in, I sent it in, and then I think Aruna picked up, there were some residents in there, so I did a whole word change thing. I think it's because using templates for some of the bits of the report, it should all be changed over, and the medical directorate should have the one with all the residents in. It's possible the wrong one has seeped through to you, but I will. I'll have another look and we'll make sure that all gets completely erased out. Sorry about that.
It's just a typo. It wasn't a massive issue. Then the other thing I was just asking was just about the hot food. With how does that work? Because you mentioned a machine. Is it just meant to be a vending machine with hot food? And
well,
how do you make
different in all different parts of the trust. I think one of the previous complaints has been that when we first started inviting the facilities people to come along, Hayley Dagger, who's fantastic, she attends regularly, there had been a complaint that the machines were just full of things like packets of crisps and bars of chocolate and no proper food. But I think the contract has been changed and there is food available, so it's dinners that they can get out and then heat up in a microwave. But I think that from what I can understand, that there are different types of machine in different parts of the trust, and obviously the resident doctors, there are lots of different buildings that house patients overnight, and different places that they go to, and not everywhere has a vending machine. So I think it's a bit of a work in process. And there was meant to be an NHS England, I think the trust were having a review of all of this, but I think it had been shelved, as far as I know. You might know more about that than me. But what happens currently is the resident doctors bring up any issues that if they've really had difficulty accessing that food, Hayley's there to go and investigate. And as far as I know, she's putting in bids whenever the contracts are up with the vending machine companies for, and I think she's talking to her bosses. If it's only a small difference in money, sometimes they're slightly more expensive if you want the hot food options, that she's fully aware that it is important that staff have access to good quality, vegetarian options, halal options, meat, veggie, they need a range of hot and cold food out of hours as well as during hours. And then the new Hastings site's going to have a whole kitchen cooking for patients and staff on board. So I think there's a huge range across the trust of what's available.
Thanks very much. I think there's a bit of a time delay on the screen there, but thank you for everything. Great report. We have noted it. Dinesh, you were a junior doctor only a few years ago. Did you want to take
I never a junior doctor. Never ever in my life have I been a junior doctor. It was a training. Just a question, has the trust signed up to the BMA charter for providing good quality food and stuff like that?
Yes, we signed up to the Fatigue and Facilities BMA charter. We did have a £30,000 grant that in 2019 that got spent, that was attached to the charter, that got spent on upgrade. About 20,000 of that got spent on upgrading all the resident doctors' facilities across the trust. We did have £10,000 left in the Guardian of Safe Working pot of money, but that was sort of clawed back into general trust funds, which I wasn't that happy about, I have to say. But that was all about 2 years ago, and we just have a small pot. There's only about 1,000 left, just over left in it, that is from fine money. But all the rooms were substantially upgraded. But then we did have a problem with items going missing from the rooms systems and security not being great. We now have Colin Dowell from security that attends regularly to the fatigue and facilities meeting, and I feel fairly assured, because the trust has altered the whole of its security with the door passes, that's been less of an issue of things going missing. But yeah, all of the actual physical charter has been laminated, and it's in every single junior doctor accommodation room. So the whole of the fatigue and facilities meeting that we have is built around that charter.
Lovely. Thank you very much. Actually, very happy about that. And no, these are really important matters. And thank you again for your management. We need to move on. Thank you very much.
Thank you.
Okay, take care. And the next item is integrated quality and performance report. Usman.
Thank you, Chair. I'm conscious we're slightly behind, so what I'll do is I'll do a brief summary, and then as ever go to colleagues, and then we'll take questions. So what you've got in front of you is the month 12 report. I think it's just worth noting. So this is the sort of end of year report. So clearly that we are now actually in June, a little bit delayed. But we'll pick up any areas where things have materially changed that people should be aware of as we just verbally go through this. So at the end of the year, first thing just to highlight in terms of areas of good performance, I think complaints handling, we had seen a really significant improvement in that over the course of the year. There had been a drop off during December and January, which we had trailed and would know about, but covered, and we ended the year delivering against our 85% target. And I think in March, actually delivered 100%. So that was a really good result. And I think we won't talk about all the reasons for it, don't talk to them, but it's the same things that we've been discussing in terms of the improvements we're doing. Staff supervision, again, we ended at 88%, which was good compared to where we have been previously. I think demonstrates the work that's been happening through our culture and OD teams, led by, well, for me and Hilary, the work they've been doing around supervision teams. And so actually getting that number up, had been a challenge for us. I won't talk about all the finance and agency spend things. I'll pick them up during the course of my finance report, but I think it is worth highlighting that we reduced agency spend from 13% of total pay bill to 6% of total pay bill. That was an enormous achievement, and I don't underestimate the impact that had on all the people who were involved in that process. But again, it's really worth highlighting we did that while maintaining all our safer staffing ratios, maintaining the teams in the clinical areas that they are required to be. And so we monitor those things all together as set out in the IQPR. I don't go through it each month, but we do present all our safer staffing ratios within here. So then just the last thing I wanted to highlight on in the areas of good performance, CAMS waiting times, I think at the start of the year was an area of concern for us. We're over 100 young people waiting over 52 weeks. We ended the year just 5. Clearly still have action to do, but that was a really significant improvement and demonstrates, I think, the process, the improvements we've made in terms of through our quality performance review meetings, the data, and bringing it together with the waiting list initiative work we've been doing, I think really demonstrates the areas, the improvement we've made. Clearly, there were some areas of performance not at target. I'll briefly touch on risk assessments and care plans just because they have been a persistent challenge for us. I think it is really worth highlighting though that while the headline number is not at target, both West and East Sussex divisions were on target. Brighton, which previously had been an area strong, had specific challenges over the last quarter relating to staffing and medical cover gaps. I think it's also worth highlighting and just being honest about that. It was also the division that was impacted quite significantly by a lot of change management programs we were putting in place through the back end of last year. The division have got a robust recovery plan in place. It's been discussed at the QPR last week, and I'm confident that they will come back. The area for us on focus will always continue to be specialist division. And we have got the additional challenge of the ND pathway weights that sit within that that's set out. I'm happy to take questions on that. The last couple of things I think just worth highlighting, PSIIs are flagged on here as an area of concern, and that's right because we've set a trajectory. However, I think it's worth highlighting that we entered the 25 year with 35. We were at 10 at the end of the year. sure Teresa just told me outside, we're at 8 now. So we continue to make really significant improvement on that. And again, that is to acknowledge the incredible amount of hard work that's gone into doing that directly from Teresa and Oliver and others I know in terms of how we get that improvement. I won't touch on MAS a lot. I might ask if there are specific questions around memory assessment. We'll go to Rob in a little bit just to talk about those. But I think it is worth highlighting that MAS has been a challenge for us this year, but it absolutely was a conscious choice because of the actions we took collectively with all of our system partners during quarter 4 of 2020. We did see and expected to see the waitlist increase. It did. There is a recovery plan in place, and we anticipate that we'd be able to reduce the waitlist to about 820 odd by the time we get to the end of this financial year. So clearly, it remains an area of challenge and focus. In terms of other waitlist issues, I mean, we talk about this every time we meet. We talk about it serious, but I guess we can't ignore the fact that our adult ND pathway waitlists continue to increase and have done consistently for 2 years now. We continue to work with our system partners in terms of what does a much more sustainable solution look like long term. For clarity, internally as an organisation, we prioritise all of the patients who come through or referred on to that. We talked previously about the idea of the red list, the clinically prioritised list. Those patients are seen clearly much faster where clinically required to. And then the last bit to highlight is talking therapies. Our 6-week performance did drop below 72%. I think it's worth saying that, again, talking therapies was an area that through the back end of last year, agreeing with our system partners, as a result of everything was going, there were staffing challenges and staffing issues there. And those were linked to, in effect, the level of trainees we were in a position to take on. New trainees were taken on in September 24 as they then come online, which is improvement in that. I think it's also worth highlighting we did outsource a significant amount of or purchase in a significant amount of outsourced capacity within the Brighton Wellbeing Service. That is now working. So part of what you're seeing in terms of the target between first appointment and second appointment within 90 days, that has deteriorated, but it was a planned deterioration as in effect we deal with all of the long waiters who are on that. And as we work through those design, we'll expect to see that recover. And I guess it's worth really highlighting that our reliable improvement rates of both services is above target. And it's been quite a long time since that's been the case. I think that focus has been really, really good. I will leave it there, Chair. But like I said, I think, Maz, if there's questions, I think Rob can come speak to those. I think if there's any others, I'll quality dashboard.
It's further open. I just think, thank you for highlighting the areas that we've done very well at as well. I mean, for example, and waiting. The neurodevelopmental pathway waiting, we reported here before, and nowhere. I mean, where we're looking at national guidance and waiting for national guidance, and it's a national problem. Just involve us. Planning from a clinical model a little while ago when we I think it was a board workshop. We need to, we'll come back to that at some stage. Jane and I will talk about when and how, so we can get more keep getting a hand on the best we can, because of course it's going a long way. Very much, Usman.
Well, I was going to mention the ND, but we'll get to it in a bit. My other question really was about the digital provider and whether it's too early or at what point we could get some outcome data on that and some patient experience feedback, because it looks like it could be really a positive adjunct to our services, but it would be good to sort of understand the impact.
Absolutely. I mean, I can say off the top of my head, I think in terms of, so we monitor all the performance metrics against it. So I think in terms of reliable recovery, for example, they're at 58%, which is probably better than what we're getting. But in terms of a full review, I think as we launch it, the team will absolutely come back. We will report back to us via QPRs, and then we'll sort of part of our board summary what that looks like. But I think there's lots of learning.
Yeah,
it's fair to say. Yeah. And I think it's worth highlighting that at this point, that outsourced provider is providing something like a third of the capacity provides the service. So hybrid model of some kind possibly is what lends itself to it.
Just a quick one on complaints. I thought it's worth bringing to the board's attention that we resolved 385 complaints through early resolution last year, compared to 300 the year before. So that's by talking to complainants to resolve their concerns. And the next phase of our ongoing improvement programme involves talking to complainants, so people who've been through the process, using volunteers to understand what that experience has been like for them, both in terms of process and the final response and the action we've committed to.
Anything else? That's for sure. Thank you very much, Usman. Moving on to being sustainable, our Finance and Investment Committee, which was held on the 23rd of May, and Anil is our chair.
Chair, met on the 23rd. There were no new risks identified or changes to the risk scores in our BAF. As an aside, I think it's important to say that I think the complexion of the committee, that means the bandwidth there of competencies and experience lends itself, in my estimation as chair, to a more rounded and fulsome conversation, albeit given the time that we had. So thank you. There are many positives. One, the very fact that last year this trust delivered a very sizable financial recovery plan means that there's no brought forward deficit into this year, which has made things a whole lot worse. At the same time, the very hard decisions that were taken last year, and moreover, the changes in practices within this trust, within finance, within clinical and other teams, alongside greater oversight and monitoring and reporting, has, alongside a great deal of hard work, bodes well as we go into this financial year. The beginning of this year started positively. Month one, you'll see SIP delivery of 3.87 million was planned, and we're at budget. And that's largely because, not only, but largely because the historic run rate for agency spend has bled into this year, and that should be applauded. So at 1.3 million in month one, that for the first time in a long time was within the NHS cap, and that should be recognised and applauded. At the same time, I think there's reason for prudent caution. As a newcomer to this area, it seems to me, you used the word zeitgeist earlier, I think the zeitgeist of this time seems to be, to me, swinging cuts socialised as efficiency savings. I'll leave it at that. But what does that tell us? Last year, not all, but a preponderance of the savings were non-recurrent. If we are to be a sustainable trust over the long term, those clinical and other changes in terms of transformation of our services articulated elsewhere today in many reports, it's going to be incredibly important. At the same time, with a financial recovery plan of just shy of 34 million, a 2.1 million stretch in addition to that which we knew last time we met as a board, is not only going to be difficult to achieve, but we know there's 6.7 million of the SIP yet to be identified. That which has been identified, 10.6 million, has been ragged as high risk. And that 10.6 million equates to 31% of the total target. And if I can conflate that 10.6 million at high risk with the forecast cash flow in Q4, which is roughly the same amount, we will have roughly 11.4 million in residual cash. It brings into sharp focus then, doesn't it, the need not just to address the low and medium SIP target, but even the more difficult stretch target, without which we run out of cash. At the same time, we know that the preponderance of the savings in this financial year are going to be delivered through workforce optimization. I think that's a beautiful euphemism for so much. But what it reminds me of, amongst other things, is that that's difficult at the best of times, is it not? It's even more difficult when we're dealing with burnout, high sickness absences, and presenteeism, and so much more that I know Anna has flagged today and elsewhere. But I'd like to draw this board's attention to the BAF in terms of the scale of the ask. And it's BAF 05, capability and capacity to deliver transformation. As a risk description, it says this: there is a risk that we do not have the internal capability and capacity to deliver the scale of transformation and change required across the organisation in light of existing demand pressures, the need for system working and co-production, failure to transition to new, more integrated models of care, significant workforce changes proposed as part of the clinical pathway, when it goes on and on. The reason I read that out is that as a board, we need to be focused. We need to appreciate the scale of the ask, be conscious of what that actually means to our teams. And thirdly, without delivery of that transformational change, the adverse impact it's likely to have on the quality of care we're able to provide those in need.
Good summary. Thank you.
Would you want me just to wrap it up as part of the month one just report as well quickly?
Yeah.
So I was going to say,
Please,
Chair's fixed covered most of it all off. Not a huge amount to say. Just want to clarify a couple of bits. So I guess just for noting, as Neil said, coming out of last year, we delivered £25 million total savings programme. 4 million of that was non-recurrent. So that's the sort of element that effect we've had to refine this year. And that will form part of the sort of ongoing conversation about that balance. But I will say at £21 million of recurrent savings, that was the highest level of savings. So there's an important point standing around the impact that's had on people. It still continues to have and will continue to have as we work through this year. In terms of, I won't go through the detail of the month one paper. I'm happy to take questions if there are any. On the CRP, on the FRP position, sorry, specifically, at the time this document was produced and written, we were labelling £6.4 million of CIP as unidentified. I think that was at the time because there was genuinely, hadn't gone through all of the governance processes that we would have needed to. We have subsequently taken some of what were previously our ideas, I will call them, and plans through some of our governance process, so that as we come to month 2 and month 3, I anticipate that 6.3 will reduce significantly to, or if not 0. What it won't do, to Neil's point, is change the risk profile. Those still remain highly, there is a high level of risk around those. So our risk level will be maintained at circa £10 million for at least month 2 while we do further work to identify that we've got all the resources in place to ensure the delivery of those programs. Because I think one big thing that we learned last year was there is no point in us saying we've got a big scheme, then are not prepared to put the resources in to ensure the delivery of that scheme. And I think we did that pretty well last year, but points I think could have made choices earlier that might have made things a bit easier later on in the year. And I think the hindsight of that is that we learned that for this year, we're already having the conversations about which of our specific programs need some additional resources to help make sure they get delivered. Beyond that, happy to take questions on any elements of that.
That's good summaries for both of you, and I think you're quite right too. It was good that you started with the achievement of last year, because it was a significant target that we made, and we did achieve it without and managing the level of our quality. That is important because, as you say, the scale of this year now is high, and it's higher, and we need to keep focus on it as a board. We'll come back to this on a regular basis, but there is a correlation between we've got a very current track record of being able to deliver on some things, but there's more to come. And this is important because it's public money. We are doing it, and we've got to get paid value for money. So that's why it's really, really important. And I think we've covered it. We've received both the reports. Thank you very much. Is there anything else? And the audit committee, which was chaired by Nitin, who's not available today. So beyond that, thank you very much.
Okay, thank you everyone. So I'm just going to go through what was discussed at the audit committee, what we're bringing forward to, just for everyone to know, this is more an assurance report than for any sort of decision or any escalation for us to take on board. Recognising this is a public board, I will explain a little bit about what the reports are for, because I think sometimes it can be a bit confusing if you're not in the finance or on the audit committee to actually know what all these different reports are for and why anyone should care. So if we go to the counter fraud, so that's just it's a report to see if there's fraud happening within the organisation, maybe fraud happening with how people are reporting if they're working in certain places. So we do spend time looking at what people are doing, what people are putting forward, so that we don't, for instance, pay someone a salary who actually doesn't work for the board. That's just an easy way for people to understand what that's all about. In terms of that, they've got good assurance on that, because all our fraud standards have been rated green. We went through the different referrals, so there were 18 referrals, 14 met thresholds for whether or not we escalate them further. We had one member of staff who was dismissed as a result, so we did quite a bit of detail talking about what that comprised of. One of the questions that did come up was if there was a threshold, a monetary value where we actually look at things. That did we say, oh, anything under £500 we don't really care about? That's not actually how we do it. We do look at the context as well, and also what sort of messaging that we're sending out to people if we just let things slide. So I just wanted to assure people on that. In terms of the internal audit, so internal audit is where we look at ourselves, at how we are running, the whole business. It's done internally. It's done by RSM. So we had a positive report on risk management. There were no major concerns. There was, so I have to go to the detail on that one again. There was a medium priority action that was outstanding, but it's not a major issue, and that is going to be cleared off, just to reassure people on that. In terms of the external audit, which is with Summer, so they reported on their progress. Everything is going as well as could be expected. The main thing that I just wanted to highlight on this one is that as a trust, the National Audit Office has chosen about 20 different trusts to look into closely. It's not because we've done anything wrong. It's just, I think it was randomly allocated and they decided to come and have a look at us. And so that means that there's a lot more work for our auditors to do in terms of what the National Audit Office want them to do. So which will cause delays. It's not going to cause delays in them giving a statement as to, how we're performing, but it could affect how they issue the certificate for us. But that's completely out of our hands, and we're not the only ones that is happening to. The finance report was brought to us, and the plan has been approved. There was an issue with. So we have issue with the work optimization plan, which has been spoken about, so I'm not going to go into too much detail. Again, we need to just recognise the external challenges that we're all facing. We know that as a trust, the amount of money, even as a system, the amount of money that's going to come to us is going to be changed. So there's a lot of pressure, on that. But that's all been taken into consideration in the CFO report. Losses and the annual reports. So we saw all the reports were given to us. We reviewed them, and we're going to get final versions due later in the month. There's not really a great deal to say on that. Finally, with the Procurement Act, essentially there's just been a new rule, just to try and make sure that when we are getting contracts, when we are writing contracts or writing tenders for people to apply for, to run contracts that we pay for, that we make sure that everything is fair and everything is publicised fairly. They're trying to encourage more smaller organisations to be able to get involved in our tenders. It doesn't really change much of what we do, because we've been actually, being pretty good at at how we do that already. This is just to make sure that we just publicise things, so things are just more transparent, to encourage other people to join. And that's it.
Thank you.
Just a couple of points to add, otherwise very helpful summaries. Just on the Sumner bit with the National Audit Office, just for the record and for clarity. So what that is in order to assure Sumner's work as opposed to our work. So this is about, in effect, the NAO making sure that the audit firms do it. So they randomly pick a set of their audits to review, and we just happen to be one of them. So it's not necessarily about us or as a random selection, it's because the firm, in effect, is. as Viola said, there should be no delay in the issue of their opinion to us, but there could potentially be a delay in the ability for them to issue a certificate, which clearly impact our sort of AGM and annual planning reports.
Right.
But we'll work that through as it comes through. As that
And we've got a couple of items left now under governance. The first one is sealed documents report.
So the board have got the sealed documents report for the last biannual period from December till May. It's set out within our standing orders that the board will receive this. There are no issues to raise, and it's here for noting, and you'll find in the appendix overview all those that have been sealed in that period.
Final one, as you see in the pack there, the annual fit and proper persons test report, which we need to do annually, and we fully comply with all the standards that we have to have. A lot of work's gone into that, and thank you, the governance team. Yeah, so we fully comply. Thank you very much. I think that takes us to any other business and reflections. Does anybody have any reflections? The only reflection I would, Usman.
Sorry, I was good. It's probably not fair to put everyone on the spot, but I was just going to say, Anil's comment about the Finance and Investment Committee, I was just going to say, I think the fact that Teresa and Oliver and others are there, it makes it an incredibly rounded conversation. That means, and that is different from how it used to be, I think. We don't just talk about money. In fact, we talk about many other things, and money kind of then arrives afterwards. And I think it then just comes through in sort of ability of the chairs of those committees to be able to help present that and then steer it. So, and then I guess we see that in the board as well. That flows.
Well, I've got to confess, I do have a dictionary. When I listen to Teresa, Oliver, John, and some of the others, dictionary there goes, what the hell are they talking about? I'm winging it, otherwise known as winging it. But thank you. No, it's not you, it's me.
It's lots of complexity. Also clinically, I'm glad you said that, and I think I paid tribute to our chief exec as well, who will always give the narrative about focusing on quality. You've got to do both. We do both, but you do need to have a proper, consistent focus on maintaining and improving the standards, quality of our services, because that's why we're here, to improve the quality of ours. Lovely. Okay. Well, look, we'll close the meeting, and thank you very much indeed. Thank you, Anna. Very much. We're going to take a 15-minute break, please, and then we'll resume. Sarah, could you put your camera on so we can